Hi, everybody. Welcome to some highlights of kinetics. Because it's important, the final version of the final exam is going to have about 5 questions on this material, so I thought I'd make a highlight for you. And here we are with some backgrounds. Similar chart from last time. Oral by mouth, cheap, very common. Um, most people don't take the pills the right way. It's really a very bizarre thing. Almost every patient who's supposed to take 30 pills in 30 days, most of them take it in 40 days, 18 days, 29 days, 60 days, and 90 days. They just take them whenever they feel like it. Sublingual is usually for drugs that cannot be absorbed rapidly by mouth, by swallowing. So instead of PO, this is SL. It goes under the tongue, bypasses all of the hepatic metabolism. So you get very rapid action and very more of an effect than if they had been swallowed. Glaucoma or infection, eye drops, nasolacrimal occlusion, finger on the bridge, in the inside of the bridge of the nose to stop the drain of the eye drop into the back of the tongue. Parenteral, IV, sub-Q. IV is the most area, most rapid, most area under the curve. Apparent volume of distribution, take-home point. Low volume, most of it's in the 42 liters in the bloodstream. High volume of distribution, on paper it looks like it'd be 100 or 200 liters. It's just an aberration due to the fact that the blood is water, and when you're testing it, most of this type of a drug that has a high volume of distribution, it's not in the water, it's in the fatty tissue, and it slowly diffuses into the bloodstream. And here's some extra ones. First order kinetics, it's a constant fraction, like 50% or 60% per minute or per time or per hour. Zero order, it's usually how many milligrams per hour, per minute that is being broken down. And first pass metabolism, this is what, like for instance, propranolol, Inderal, 40 milligram tablets go through the liver. There's like 1 milligram left by the time it gets out, the equivalent of 1 milligram IV. Definition of a prodrug is here. Now the cytochrome P450, phase 1, major rearranging. It doesn't really introduce. It's more removing. Its main job is to remove or expose these functional groups to make it slightly more water soluble, not fat soluble. But a lot of drugs have fatty components in there. And this tends to make them a little bit more water soluble. And then the second phase, which adds some sulfates and glucuronides and some other acetates, some other conjugations to it to make it even more charged, so then you can pee it out. It's a matter of making it get out of the body. The elderly are usually deficient in phase 1 because this is an energy-driven process by more or less ripping apart and deaminating, taking amino groups off of drugs. So phase 2 stays for constant, but phase 1 diminishes in the elderly. It's going to be important next semester. Inhibiting the drug, the cytochrome P450 enzyme means that the drug that's also the target drug, some other drug, it can increase that concentration and cause an overdose. Remember, it doesn't inhibit the drug, it inhibits its breakdown. So you get a higher effect, where metabolism, induction, is just the opposite. Cockcroft and Galt, 2 doctors, they devised this formula, 140 minus age. So the older you get, the top gets bigger. The higher the milligram of the serum creatinine, the bottom gets bigger. So if the top, so if the age gets bigger, you're taking it off 140. So the higher you are, the top gets smaller. Now on the bottom, the milligram percent, this shows how much of that serum creatinine is backing up. So 1 milligram percent is normal. 2 milligram, 3, 4, 5, 6 milligrams, that means there's less and less clearance out of the kidneys by these person's kidneys. And just remember, increase in age, lower value of fraction, lower GFR. Increase in serum creatinine, lower volume, lower GFR. And it's expressed in milliliters per minute of blood that's being cleared of that creatinine. And this is the An acid in an acid would be less able to bond with water, so it gets back into the body through the renal tubules. An acid in a base, more charged, the pluses and the minuses are attracting each other, and it'll be more soluble in water, easy to pee out. And the same with bases, the opposite with bases. Now, remember, here's something with a low therapeutic index. Toxic dose is very close to the effective dose. This is a lot safer, 20. If it was 50 or 100 or 200, that would be best, like penicillin. I mean, you could take so much penicillin in most cases, and the therapeutic index is enormous. It's a very safe drug. Important terms to look through. Get to know these definitions here. Area under the curve, very important. And the loading dose is you're loading up a high dose to get it into the bloodstream real fast for emergency use. And a bolus dose is a big round, like a big round ball, but you're just giving an immediate dose of a large amount. And that's it in 6 minutes. Happy snippet. Lots of luck. There will be a few questions on the test from this material. It'll be around 4 or 5 questions. Lots of luck. Any questions, email.